Hello and welcome everyone to the McFarland Clinic and Mary Greeley Medical Center and the William R. Bliss Cancer Center webinar, Breast Cancer Screening, What You Need to Know and What You Need to Do. My name is Shelley Jakey. I'm the Marketing and Public Relations Director for McFarland Clinic, and I'll be serving as your host and moderator for today's webinar. Our speaker today is Dr. Sunem Patel, McFarland Clinic oncologist who provides services with the William R. Bliss Cancer Center. Dr. Patel will be covering information on what breast cancer is, some statistics associated with it, the importance of screenings, and what to do if there's an abnormal result. And of course, we'll be taking some time at the end of the presentation for questions that you might have. Well, at this time, I would like to introduce and turn over to our physician and expert speaker, Dr. Patel from the McFarland Clinic Oncology Department. Good afternoon, Dr. Patel. Glad to have you here.
Hi, thanks. I'm glad to be here. So thank you all for coming. I think this is an important topic because one, it's October, it's Breast Cancer Awareness Week, but breast cancer in general is just a disease that affects a lot of people, directly or indirectly. So I think it's important to talk about it. I just wanted to jump off, starting to talk a little bit about statistics. I mentioned that breast cancer affects a lot of people. It is the most common cancer that is diagnosed in women, about 13%. So about like 1 in 8, 1 in 9 women will have a breast cancer diagnosis, which is fairly significant. It is the number 2 leading cause of death in women after lung cancer. This graph over here is from the SEER database, which anyone can look up online, and gives us statistics in the recent years about breast cancer. And you can see over here in 2025, it's estimated that about 300,000 women, about 15% of the population, will have a new diagnosis of breast cancer. It's estimated that this represents about 7% of cancer deaths, which is actually on the lower end because we do fairly well in terms of detecting breast cancer and treating breast cancer early, which has a lot to do with the screening that we're going to talk about. When people are diagnosed with breast cancer, 92% of people will live at least 5 years. And again, a lot of that has to do with how early it's detected, what stage it is. So this includes all stages, not just people who come in with a very early breast cancer. This graph below shows 2 different things. One, that top line that's in light green shows the rate of new cancer cases. And what's important, I think, to get from this graph is that it is about steady. You can look back to 1992 to now. The number of cases has not really gone up or down. It sort of just has stayed about flat. What is a good thing is that you can also see on the lower bar, the dark green, that the death rate associated with breast cancer has decreased. You can see a very steady decreasing line from 1992 to 2023. And this has a lot to do with the improved treatments that we have and the better detection that we have as well. We can go to the next slide. So what is breast cancer? So cancer itself is really abnormal cell growth. And this just has to do with a mutation that might occur as your cell is normally dividing that causes it to proliferate or invade or behave in a way that is abnormal. These are a few different words that you might see or might hear when you talk about breast cancer. And the first one is invasive versus in situ. So invasive cancer really just means that this cancer has developed, these cells, have developed the potential to spread somewhere else in your body. And that's what makes them invasive. In situ are cancer cells that occur, but they have not yet developed the ability to spread or go anywhere else or travel outside of the area that they are currently. There are 2 main types of breast cancer, although there are a bunch of different subtypes that are rare. The 2 most common ones we see are ductal and lobular. So if you kind of look at the image on the right-hand side of the screen, you can see that the lobules are those pink circles. That is where the milk is generally made. And those leads, if cancer develops in the breast in that area, that would be a lobular cancer. And then the second area, you can see those little lines that lead all the way down, that's labeled duct. That would be where ductal carcinoma or ductal cancers develop. There are a lot of different tests that we do on breast cancer once we have a diagnosis. And the first one is an estrogen and progesterone receptor. And so what we're looking for there is whether or not the cancer responds to estrogen or progesterone as a growth signal. And then the second marker over here is HER2 positive. That looks at another marker on breast cancer cells that can give a growth signal to them. And then the last subtype of breast cancer is a triple negative breast cancer, which basically just means it does not carry an estrogen receptor or a progesterone receptor or a HER2 mutation. So those are the different kinds of breast cancer that you will see or hear about. Next slide. So Cancer Screening 101, just a little primer on what screening tests are and what their purpose are. So a purpose of a screening test is essentially to find cancer before it is advanced. We want to find it when it is still something that we can treat and get rid of and improve survival and outcomes. So what makes a good screening test? So screening tests inherently are tests that we put a lot of people through. So meaning it is something that we do day in, day out for a lot of people. So it has to be something that is fairly quick so that we can manage to get everyone screened. It's low cost and effective. That is the most important. And then another really important thing is we want it to be low risk. So we want these tests to be something that we can do easily, that won't take a lot of time, and that gets us the answer we need without too much risk to the patient. Some examples of screening tests that you've all heard of: colonoscopies, mammograms, which we'll talk about in detail coming up, and pap smears as well. So moving to specifically breast cancer screening, this is a very, very complicated sort of history. There are different societies. There's the American Cancer Society, there's the National Comprehensive Cancer Network, there is the gynecologic societies. A lot of societies have different guidelines on screening for breast cancer, and they all have slight differences. So what I've done here is, this is just sort of like a general framework to be aware of, but obviously it is individualized and should be discussed with your doctor based on your health. But how we approach, or how I approach breast cancer screening, is to look at the patient's risk. So we divide people into average risk, moderate risk of breast cancer, or high risk breast cancer. So those who are average risk, when you're aged 40 to 44, mammograms are usually recommended every 1 to 2 years, based on most guidelines. Most people in most guidelines tend to defer to saying once a year annual mammogram in that age group. Between the ages of 45 to 74, most guidelines say annual mammogram is the standard, and definitely beyond 50, you should be getting an annual mammogram. After age 75 and above, this is a question that I actually get a lot. It is an individualized decision with your doctor. And how I look at it and what I tell people is, it really just depends on what your goals are and what your health is. If you have excellent health, are able to undergo surgeries or treatments if something was found, and have a reasonable life expectancy, you're doing well, then I think it is very reasonable to continue breast cancer screening. But if you ever sort of look at yourself and say, hey, I don't know that I would want treatment, or I want surgery, or I don't know that I would tolerate it, and you're age 75 or above, then maybe it's worth discussing with your primary care doctor if you need to keep continuing to do mammograms or not. The next category is moderate risk patients, so people that have about a 15 to 20% lifetime risk. We still tend to follow the average risk recommendations that I just discussed, and that's mostly because clinical trials and studies have not really shown any benefit to doing more screening tests in this population. That's different than the high-risk patients. So these are people that have a 20% or higher lifetime risk of breast cancer. And for them, we typically recommend enhanced screening with a mammogram annually, like normal, but also adding on an additional scan. And that can look like an ultrasound, which we'll talk a little bit about, or an MRI in addition to that. So usually what I do is stagger them, meaning you get your mammogram. For example, if you got it in October, you get it in October, and then 6 months later, next April, you'd get your MRI or ultrasound, and then 6 months later, you'd get a mammogram again, and then you just sort of go back and forth. It is very acceptable also to do mammogram and MRI or ultrasound at the same time, just for convenience sake, but making sure that at least once a year you are getting both of those done is important if you fall into this high risk category. So I mentioned a lot about risk, particularly high risk, average risk, medium risk. And so what goes into this? And there's a huge amount of things that go into it. And it's not something that we expect you as the patient to find out on your own, but it is something that, mammograms look at, doctors look at, and that we want you to be talking about with your primary care providers. One of the main ones is that there are risk calculators, and these are available online, and they are also calculated with your mammogram and are reported to your doctor and are something that they can review. There are two main models, although there's a lot. The Tyrer-Cuzick model is one of the most common ones, and that tends to include breast density in its calculation, which is really important, as we're going to talk about a little bit later. And then the Gale model, which is particularly good at involving family history. But both of these can give us various numbers. They can give us 5-year risk, lifetime risk of developing breast cancer. And so, kind of reinforcing what we talked about last time, if your risk of getting cancer over your lifetime is greater than 20%, then you do qualify for getting that enhanced screening. So it's important to have these numbers calculated. If you are not sure, you can always ask your doctor, but they are generally assessed with your yearly mammogram. Family history plays a lot into this, particularly if you have a family history of breast cancer in your nearest family relatives, so like a sibling or parent or child. It's really important to share that information with your doctor, and when they ask with your mammogram, input that information, because that helps calculate your risk accurately. There are some genetic conditions that can cause you to have increased risk of other cancers like pancreatic, ovarian, and prostate cancer that can also be associated with increased breast cancer risk. So it's important to also report other non-breast cancer related diseases with your primary care doctor. And then lastly, what ties into some of the risk determination is your own personal medical history. And we're going to talk a little bit more about that in the next slide. So I'm going to draw your attention to the left side of this graphic. So this is a graphic that the Cancer Center has created to help talk a little bit about risk factors, what risk factors you can control and what you can't control. So on the left side of this graphic, these are the risk factors that you can't control, and a lot of them tie into personal history. So, for example, that first one, if you've had a history of radiation to the chest, particularly if you were younger, that is a risk factor that puts you at increased risk of breast cancer, and you should be getting enhanced screening through that. We talked a little bit about how there can be familial genetic mutations that contribute to this. Family history, we just sort of reviewed. And then the last two are your menstrual menopausal history. So having menstrual cycles start at a younger age and going through menopause at a later age can slightly increase your risk of developing breast cancer. And again, this is all factored into a lot of those calculators that I mentioned. And then lastly, dense breast tissue can increase your risk of breast cancer. So these are all factors that are sort of just inherent to your health that are not always something that you can control, but play into which category you fall into. The next slide. So I mentioned that increased breast density can increase your risk of cancer, and there's a couple different reasons for this, but first I wanted to kind of define and explain what breast density is. So a normal breast, as you can see in sort of the right upper side of this, is composed of the skin, and then there's blood vessels and lymphatics. Then there are ducts, so again, those thin pink lines in that smaller photo, and then glands, which are like the lobules where the milk is made, and then the yellow tissue around it is the fat in that picture. So when we do mammograms, which are x-rays, we get these pictures that look like what we see on the right, the A, B, C, and D. The white areas are representing ducts and glands. And so you can see as you go from A to D, that increasing white area is increasing density. So you can imagine it's harder in that D picture to detect small masses than it is in the A picture. And then the dark areas represent fatty tissue around it. And so those appear dark and black. So essentially, increased density means that you have higher amounts of ducts and glands and white tissue compared to the dark areas. When you get your mammogram, you might see a CAT classification of breast density that's listed here on the left. They will give it an A, B, C, or D. And that assessment is really between two different things. One, the radiologist will take a look and give their thoughts on it, but a computer-generated result is also factored into it. So A breasts are mostly just fatty breasts. B has scattered densities or scattered areas of ducts and lobules. C are heterogeneously dense, and that really just ties to the area that there are some areas that are dense, some are not. Small masses or small abnormalities can sometimes be obscured in this. And then D are very dense tissue. That was the one all the way to the right where a lot of the breast looked white. It really can lower the sensitivity and the ability of the mammogram to catch small things. So what we define as dense breasts is anyone who has a category C or D density breast. So anytime you read your mammogram, you should be able to see this classification on there, and you should be able to kind of correlate that with what it means. C or D density breast is fairly common. It can be in about 40 to 50% of women. So a lot of women will see this in their mammogram at some point in their lifetime. There are various factors that affect density. A lot of times I get asked, is there anything that I can do to change this? And usually it is something that is just inherent to your body. Your age plays into it. So the older you are, the less dense your breasts are. Your menopausal status plays into it. So meaning premenopausal women tend to, in general, have denser breasts than postmenopausal women. Menstrual cycle, so particularly where you are at within a menstrual cycle, is important and can affect your breast density, which is why sometimes radiology will want your MRI or your scan done at a certain part of your menstrual cycle. Genetics plays into it, so just familial breast density. Your history of childbearing, your body habitus plays into it, and then use of hormone replacement. So people that are on hormone replacement therapy will have increased breast density compared to people that don't. Now, just a note, I mentioned that breast density increases your risk of cancer, and there's really two sort of thoughts behind it. One is that it's obscuring small masses, so it just becomes harder to detect. But two, the more glandular tissue, the more ductal tissue you have, the more areas could potentially develop a breast cancer. So there's two different really sort of thoughts and reasons why increased breast density can lead to an increased risk of breast cancer. So now that we've talked a little bit about sort of the background, our next sort of steps are talking about, well, what can we do? What are the screening tests? What options do we have for this? And the first thing and the main thing that everyone, all women and men, should be aware of is personal breast awareness. It really just means that you should understand what your breast normally feels and looks like. Is there normally nipple inversion? Is your nipple normally retracted? Is there, an asymmetry? Is one side normally bigger than the other? Just being aware of things like this. That way, if there is a change or something different happens, you are able to bring it to the attention of your doctor. Specifically, symptoms that are important that you look for are one, lumps, which is what a lot of people are aware of. And this can range in size, right? This could be a small lump that's the size of a pebble that's new and firm, all the way up to a bigger lump. Anytime you feel this should be reported to your doctor, and more testing should be done to evaluate for it. Swelling and redness that persists. Sometimes it can be an infection that needs to be treated, but sometimes it can be associated with malignancy or cancer, so it's important to know about it. Persistent pain, particularly pain that doesn't seem to change with your cycles, pain that doesn't seem to go away after a couple weeks, or pain that is specifically in one area and does not deviate or move around. Those are sort of warning signs and symptoms to be aware of and report. Nipple discharge, so breast milk can sometimes be normal, but if we see bloody discharge or discharge that just seems abnormal to you or different than normal, different than what you normally see, then that is important to bring to the attention of your doctor. And then lastly, persistent swollen lymph nodes, really anywhere should be reported to your doctor, but Specifically in terms of breast cancer, if you feel any around your breast or under your arm, those are important to note. I will make a comment on swollen lymph nodes is that sometimes if you are sick, you have an infection in that area, or potentially even got like a vaccine within the last week or two, you can have swollen lymph nodes, but the difference with those is that swollen lymph nodes related to illnesses or vaccines should go away within a week or two. And if it is not, then you need to be telling that to your doctor so that they can help work it up more extensively with you. So we talked a lot about breast cancer screening options, and so I'm going to go through the three main exams that we have to look for breast cancer. And the main one is a mammogram. So this is a 3D X-ray essentially that sort of gives a reconstructed view of your breast that the radiologists are looking at. They're looking for abnormalities. Specifically, they're looking for any asymmetry or calcifications, which can present as little white dark dots on the X-rays. These abnormalities can sometimes signify an underlying issue. Sometimes they are just benign disorders. So they're not always something to be concerned about, but they're always something to be monitored and looked at. The pros of the mammogram is that it is very quick, it is low risk, and it is very effective at doing what it does in most people. The drawback is that with people who have more dense breasts, it can sometimes miss smaller masses. Now, a question that often people get asked, I get asked, particularly in women who have denser breasts, is, well, do I need a mammogram? Shouldn't I just do the MRI? And there is still a utility to the mammogram, especially in dense breasts, because again, calcifications, that sort of thing is actually better detected on the mammogram. So no matter what your density is of your breast, no matter what, mammograms should always be done annually if you fit into that age range of screening. And so then the other two options that we have are MRI and ultrasound. So again, these are options that are typically reserved for women who have dense breasts on their mammogram or an elevated lifetime risk of breast cancer, kind of through the calculators that we talked about earlier or through their medical history. The first one is a magnetic resonance imaging. So it is an MRI that uses magnetic technology to help get an image of the breast. The pros is that it is very, very sensitive. It can catch really small things. Sometimes things that may not always pop up as clearly on a mammogram can pop up on MRIs. It overcomes issues with dense breasts. So even if you have dense breasts, we still get good imaging, we still get good results. The cons are that it is a longer scan. It can take, there's an abbreviated version, which can take 15, 20 minutes, but then there's longer versions, which can take up to 30, 40 minutes. Anytime that you have a test that is highly sensitive that can pick up really tiny things, we run the risk of a higher rate of false positive results. So meaning we might see something, it might look suspicious, we might put you through a biopsy, but it could be nothing. And so that is a risk that we have to understand with these scans, is that people inherently will go through more biopsies than potentially necessary. And then lastly is that there are a couple reasons why we may not be able to give you an MRI, and that may be that certain types of metals, pacemakers, or ICD devices are not always compatible with an MRI. So that's important to note when someone recommends this or talks to you about this. And then there is an IV contrast that is used with MRI imaging. And so certain severe kidney dysfunctions may not be eligible for an MRI as well because of that. Now, we do have an alternative, which is an automated whole breast ultrasound. So essentially, anyone can get this scan. There's really no contraindications to this scan. It is safe. Cons are that it is a little bit less sensitive than the MRI, but it still does do a good job at looking at the whole breast and trying to pick up on anything that might be abnormal and might have been missed by the mammogram. So this is just a picture. I wanted to give everyone a sense of what it's like. So this is a depiction of an MRI. So what essentially will happen is that big blue machine is the MRI. You'll be placed prone on a table, and there's usually a little device there to hold you up so your breasts fall into an area that's separate from your body, and then they will put you in the scanner. And you have to stay in that position for a reasonable amount of time, depending on if it is an abbreviated MRI or if it is a full screening MRI. And then this is a picture of an ultrasound. So a lot of women have had ultrasounds through pregnancy or other tests. It basically is where they put a cold jelly on your breast and they can use ultrasound technology to kind of recreate images of tissue that is denser than fat. And so you can sort of see on the screen, there's a small lump there, and that's kind of like the image that we get with ultrasounds. It is a little bit of an easier test to tolerate. And again, this is something that is available to most, if not all, women. So the next thing I wanted to talk about is what if there is an abnormal result? This is a very scary situation and can create a lot of stress in someone if they have an abnormal mammogram. So the first thing that I will say we do is we want to confirm the presence of an abnormality because scans are not perfect, and sometimes we will find an abnormality that upon magnifying that area, we won't see anymore, or it was just related to the angle of the imaging. So not every abnormal MRI or mammogram is something of concern or is cancer. So we will definitely do a focused mammogram of that area, and we often will do a focused ultrasound of that area as well to make sure that abnormality is truly there. Most of the time, they'll find that, oh, that was not there. It was just related to how the tissue was lying. We can just go back to regular screening. But if there is an abnormality that's confirmed, you can sort of see in the next line over here, usually what will be recommended is a biopsy. And that is because we need a sample to tell us if it is cancer, and if it is cancer, what type. So thinking back to earlier in our presentation when we talked about the ductal, in situ, invasive, we want that sort of information to help guide our next steps. So the biopsies are usually performed with an ultrasound or with mammogram guidance. Sometimes if they can't detect the abnormality on ultrasound or mammogram, they will have to do an MRI guided biopsy as well. And generally, this is a procedure done with the radiologist where a needle is inserted using the image into the area of concern, and then they take multiple samples and passes, and then this is sent to radiology or pathology, where they will then look at it microscopically and see if they see anything abnormal. Sometimes the abnormalities we see are benign. There are benign breast tumors, things called fibroadenomas, papillomas, that don't necessarily always need intervention, but then there are also obviously cancer diagnoses as well that come from these. So if a cancer is diagnosed, typically what will happen is your primary care doctor or whoever is ordering or managing the mammograms will be called. And then it will be recommended that a referral gets made to both surgeons and medical oncologists, as these are the two people that will sort of help guide and determine next steps. There are a lot of different things that can happen in this situation, so every case is individualized. So I just wanted to kind of give a general overview of what might happen. So depending on what type of cancer was found on the biopsy, how big it is, sometimes more imaging is needed to help get a sense of where this cancer is located or how big it is or how involved it is. Sometimes you might need another biopsy if there's an abnormality that's undefined or if there's an area that just looks different. Sometimes another biopsy might be recommended. Surgery, and we'll talk about that in a second, or sometimes if it is a triple negative breast cancer or a HER2 positive breast cancer, chemotherapy or targeted therapy first might be recommended. It just depends a lot on what stage it is, where it is, what kind it is, a lot of detail that is individual to every person. Surgical options, and again, we're just going to kind of briefly talk about it because it can get very involved for breast cancer. Generally tend to include either a lumpectomy, where they just remove the area of the breast that has cancer, or a mastectomy, which removes the whole breast. If it is a generally small cancer, then the choice oftentimes is left up to the patient, meaning you can choose to just have the area removed or you can choose to have the whole breast removed. And the reasoning is because with early cancers, there's really been no improved survival or outcome or, decreased cancer recurrence rate by doing the mastectomy compared to the lumpectomy. And that's largely because we have a lot of good options like radiation, or anti-estrogen pills to help prevent recurrence in the future. Now, some women might choose a mastectomy just due to personal choices, or because they have a family history that's concerning, or they have a personal history that's concerning. That is absolutely a choice. And anytime someone chooses a mastectomy, it's important to understand that you also do have the option of reconstruction available to you, meaning sometimes women will want an implant reconstruction, which is where they put either saline or silicone implants under the skin to look like the shape of a breast, or a flap reconstruction could be considered, which is a more involved surgery where they take skin off of your abdominal wall or thighs, and then they reconstruct it into the shape of your breast on your chest wall. But again, what choice is right for you? It really depends on a whole series of things, such as how big the tumor is, what area it's involving, your personal history, as well as your personal choice. But these are the general options to be aware of. So moving on to sort of the last part of the talk, I wanted to talk about, well, what can you do to reduce your risk of developing breast cancer? And so I'm bringing back this graphic, which shows, again, on the left side, risk factors that you can't always control, but on the right side, which we're going to go over right now, these are risk factors that you can control. And the most important one is probably exercise. So regular exercise decreases breast cancer risks by 10 to 20%. It is a great thing for your heart health. It's a great thing for your body, your energy, but also with risk reduction for breast cancer. So maintaining a normal BMI and a healthy weight can also reduce your risk. And this is a really complex mechanism, but essentially, if we boil it down, it comes to the fact that adipose tissue or fat cells can help produce estrogen, so those levels are a little bit higher in someone who is overweight or higher BMI. Smoking. So smoking not only increases your chances of a lung cancer, but it also can increase the risk of damage to breast tissue and disrupt cell growth, and again, increase your risk of breast cancer from that. The other big thing that we do know is tied with breast cancer development, as well as recurrence if you've already had breast cancer, is alcohol consumption. So if you are drinking 1 glass of alcohol every single day, you can expect that there is an increased risk of breast cancer. That's about 7 to 10%. And the more alcohol you drink, that number goes up. So cutting down or cutting out alcohol completely will also help protect yourself against developing breast cancer. Reproductive history. So I mentioned earlier that your risk of breast cancer is tied a little bit to your history of menstrual cycles, menopause, but it is also tied to whether or not you had children. So if you had children, or if you did not have children, sorry, or had children later in life, this can be a slight increased risk of breast cancer, as well as not breastfeeding. And this again has to do with the hormonal regulation of your body and your exposure to estrogen alone. Hormone replacement therapy. Now, this is a pretty hot topic. There are a lot of studies that look at this, and there's a lot of nuance to this. So it is something that you absolutely should talk to your individual doctor about. But as a general sort of statement to make, being on hormone replacement therapy for long periods of time, so years and years, can slightly increase your risk of breast cancer. Now, this does not include people who are just menopausal, who are on short periods of hormone replacement therapy. Those are safe and effective at helping with those symptoms, but we're talking about people that are on years and years of long-term hormone replacement therapy. So that is something that you could potentially consider or address. So I didn't really talk about male breast cancer in this talk, but I wanted to at least give one slide to it. That way people are aware, because men can get breast cancer. They do have breast tissue, they do have those glands and ducts. And so men are not routinely screened, and that's just because they don't commonly have breast cancer. But men should be aware of what their breasts normally feel like, and they should report changes, particularly if there's a lump, swelling, nipple discharge, nipple changes. They should report that to their doctor. We have a similar graph to what we are diagram to what we just talked about risk factors that men can control and that men can't control. And a lot of the ones on the can't control side are very similar. So the older you get, if you have a familial mutation that you know about or familial history, your risk is higher. History of radiation to the test, or if you have certain testicular conditions like undescended testicles or surgical removal of testicles, that can also increase your risk. And that has to do with, again, higher levels of estrogen in your body. This can also be tied to high levels of estrogen that come from cirrhosis, liver disease, obesity, and then kind of tying on with the genetic mutation family history. On the side of diseases that you can control, similar to women, exercising frequently, having normal BMIs, minimizing alcohol consumption, and cutting out smoking are all things that can help reduce a man's risk of breast cancer. So if a man in your life, or if any men are listening here and you feel a lump in your breast, it is important to let your doctor know. And it is likely that they're going to recommend a mammogram, possibly an ultrasound, to explore it further, because there is still a possibility that you could develop breast cancer. So just some broad conclusions. If you are younger than the age of 40, it is important that you just are aware of what your breasts normally feel like. That way, if there's a change, you can bring it to someone's attention. You should discuss your breast cancer risk with your doctors, particularly if you have a family history of breast cancer or if you have any of those high-risk conditions that I mentioned earlier. If you are between the ages of 40 and 75, you should be getting regular mammograms, likely annually. And then age 75 and beyond, you should discuss continuing mammograms with your doctor based on your health. And if you are at an elevated risk of breast cancer, remember that you should be getting your mammogram annually and likely should be considering another scan, such as an ultrasound or an MRI. I think that is everything I have. Thank you for listening, and I think we can take questions.
Okay, well, thank you, Dr. Patel, so much for taking time to share your expertise on this very important topic. Reminder to everyone who's on the webinar that you can submit questions using the Q&A button. So go ahead and do that. I'll be looking for those to come in here and can share those with Dr. Patel to answer. We're just waiting maybe for a few to come in. I realize it might take people just a little bit to type in. So as we're waiting for a couple questions to come in, I do want to highlight that we do have another webinar tomorrow. Welcome to Medicare for those that are 65 and older or approaching 65 or have a family member who is Medicare eligible and you want to help that person navigate. This is a great webinar as well to tune into. You can register for that on the McFarland Clinic website. So I'll take a slide back here in terms of how you can submit questions. Dr. Patel, I don't have any quite yet in, but I know that we had someone that sent in prior to this who was asking a question about if someone has had a mastectomy, had their breast removed, do they need to continue to do some sort of screening for breast cancer? What happens in that particular case?
It's a good question. So if someone has had a mastectomy, and I'm assuming, well, let's just say someone has had a mastectomy, that means that their breast tissue has been surgically removed. So if they have no history of cancer and had a mastectomy, then they do not need any further screening because there's no more breast tissue for the cancer to develop in. Now, this does not apply if you had a mastectomy on one side. If you still have one breast, you still need to get the regular screening on the other side. But if you've had both sides removed, that is the case. Now, if you've had mastectomies for cancer and you've had a history of diagnosis of cancer, then you should be getting routine exams, physical exams of that area just to make sure there's no abnormality. But again, there's no more breast tissue, so there's no mammograms that are needed. Sometimes MRI breasts can be considered if there is a reconstruction or an implant, but that is not meant for breast cancer screening. That is actually more meant to look at the implant and make sure that there's no abnormalities there.
Okay. Another one that's come in. If you've had a benign cyst finding on a mammogram and ultrasound, what should you do next for a benign cyst?
Yeah, so if it's confirmed and the radiologist is sure that it is a benign cyst, then there is not anything further you need to do. Sometimes if they are uncomfortable or cause discomfort, pain or something that bothers you, then you can see a surgeon to get it removed, but it does not need to be removed. Sometimes cysts can be related to caffeine intake. So sometimes reducing caffeine intake might be able to help decrease it. But again, it is not cancerous. It is not something that needs to be dealt with other than if it bothers a patient.
Okay. Next question. Does use of birth control, especially over several years, affect your risk of breast cancer?
It's a good question. There's no strong studies to say that there's a huge impact on your breast cancer risk. There is a recent-ish study that looked at IUDs, hormonal IUDs, and their risk on breast cancer. And there is some suggestion that there's maybe a slight increase in your breast cancer risk. Again, none of this has been significant enough to make any changes to the recommendations. I personally would say that if someone has an IUD and has already high risk of developing breast cancer, then it might be worth exploring further. But usually people who have a general health don't need to make any changes on these medications.
Okay. I was just thinking about, the coordination that you're saying when something abnormal is found and a cancer is confirmed, the coordination between the medical oncologist and the surgeon. How does that usually happen? Are you seeing the surgeon first and then the medical oncologist? What does that look like when someone is needing to have that level of care?
Yeah, and it's different in every situation. Generally what will happen is once there's an abnormal test, the referral is placed to both people at the same time. And so you might see a surgeon first, you might see an oncologist first, but they're essentially going to both sort of talk about very similar things, which are what are your surgical options? What are your next steps? But it is important, that they coordinate and talk. And that's definitely what happens, in our situation. If it's sort of clear what the plan is, we will message or send our note to the surgeon. Sometimes if there's a little bit more of a complicated situation, we will talk. And then every case of breast cancer that is treated at McFarland gets run through our cancer case conference. And so we review every single case with a group of radiologists, surgeons, pathologists, medical oncologists, and radiation oncologists. So they're all reviewed typically after surgery, but sometimes they can be reviewed before if there are abnormalities that we can't reconcile.
Thinking about the resources that are available with the William R. Bliss Cancer Center, there's the Cancer Resource Center. What are some of the resources in the Cancer Resource Center available to women who may have concern about family history, or maybe they now have a diagnosis? Can you speak to some of those resources?
Yeah, there's a lot of resources at the Cancer Resource Center. And so I think I would just say, starting with, we have cancer navigators. We have nurses who have a lot of experience in dealing with breast cancer patients, kind of knowing how to navigate the system and helping with everything from like treatment related questions all the way to helping figure out resources for bras or prosthesis if you've had surgery. They also have a geneticist there that can be helpful if you are concerned about your family history or want to explore the idea of genetic testing. Because of your family history. They have actual like physical resources like books and stuff to read about breast cancer, particularly helpful after you have a diagnosis, but it can also be helpful if someone's trying to gain more information. So a lot of different things that can be of help to people who maybe don't have cancer, but possibly a family history, but also a huge amount of help to people who do have cancer and need help with a lot of information gathering and navigating the system.
Okay. I have another question that came in as well. When is an MRI needed, and should everyone get at least once? Should everyone get it at least once?
So an MRI is needed when you have dense breasts. So that means if you have a category C or D density breast, an MRI should be considered. But again, an ultrasound is a reasonable alternative. Or if you have any of those high risk situations, meaning if you have a history of radiation at a young age, or if your lifetime risk of breast cancer is greater than 20%, or if you are known to have a genetic mutation that increases your risk of breast cancer. So those would be the reasons to get an MRI. Outside of that, there hasn't been any data or any evidence to support that everyone should just get an MRI without any of those prior conditions. Because again, that carries a risk of overdiagnosis. It carries a risk of finding something that doesn't always mean anything and putting people through biopsies, anxiety, and stress for possibly a normal finding.
I think about when you're talking about self-awareness, and sometimes people have, oh, the first of every month you should be reminded to do a self-exam. What's your recommendation on the frequency when we say self-awareness? Is there some things that people should be doing on some sort of cadence?
Yeah, so there used to be a lot of push for monthly self breast exams, and that's still absolutely a very valid option, but the general shift has been away from that. And the reasoning is because, I think created a lot of pressure that, oh, the person needs to find something and not everyone knows what they're feeling, what they're looking at. And it really hasn't been proven to say, hey, self breast exams lead to this. But I think it is reasonable, if you need sort of that reminder once a month to just sort of say, okay, here's what my breast looks like. This is what, is normal for me. This is how my nipple normally looks. This is how the left breast looks compared to the right breast. And then that way, if you are doing it on a regular fashion, you notice changes. But there's no specific, oh, you need to do it once every 2 weeks or something like that. I would definitely say probably not necessary to do it more than once a month.
Okay. Another question about insurance. Does insurance usually pay for these additional tests if they are recommended, these screening or tests that you're visiting about?
So a mammogram should always be covered because it is preventative care. Whether or not an MRI and ultrasound is covered depends a little bit on whether or not you have those conditions. So if your lifetime risk is greater than 20% or you have dense breasts, most of the time there will be pretty good insurance coverage. There used to be, we used to have some trouble getting insurance coverage for abbreviated screening mammograms, which is what a lot of women who had like category C breast density used to get. But now a lot more insurances are covering it. So it a little bit depends on your insurance coverage, but in general, we are getting better coverage, especially if you meet those various parameters that I talked about.
Okay. Another question here. Can you explain the risk of lymphedema and what it is for someone who has undergone treatment for breast cancer? Who's at risk for lymphedema and what can be done to address it?
So lymphedema is essentially where your arm or sometimes your breast or underarm can get swollen or filled with fluid after breast cancer treatment or surgery. And this just has to do with the fact that during a lot of those surgeries, lymph nodes will be removed. And so just how your lymphatics drain changes and is different. Um, the risk varies depending on what type of surgery is recommended. So what I mean by that is the risk is fairly low in someone who maybe just has one or two lymph nodes removed versus someone who's had 15 or 20 lymph nodes removed for more advanced breast cancer. Those people are more at risk. Plus, then when you do radiation, that adds to the risk of lymphedema. So it really just depends on every individual situation and how much of their lymph nodes were removed. What can be done about it is being proactive with physical therapy is probably the biggest thing that you can do. Wearing a compression sleeve or a compression hand garment, both of those things can help prevent it and it can help treat it, but also following with physical therapy, doing sort of exercises and maneuvers that they teach you is important. Lymphedema can progress sometimes pretty rapidly, and the worse it is, the harder it can be to kind of come back to normal. And so it's one of those things that if you start to notice it and you've had breast cancer surgery, it is important to bring to the attention of your doctors so that we can get you to the physical therapists promptly.
Okay. Well, that seems to be it for the questions right now. Dr. Patel, any other one piece of advice you would give the participants here in terms of cancer screenings or even preventing breast cancer in particular?
Really, other than just make sure you're getting your mammograms and staying on top of it, I don't think there's anything else. I think it's just important to keep doing it year in and year out and be consistent.